ago. And now we are ready to start. We are so happy to have you here again in this new series of ECO, cardiovascular management in primary care, stratification of risk in management of complex cases. This is part of a series that we will be having with you every week, every Tuesday for 8 weeks. We are going to start. Remember that on the chat, you may type your name, last name, your specialty, the municipality where you work, and if you are with your colleagues, the same way, they should include your colleagues' information. If you're going to share the link, then the person who used the link on the your box, you should go to the 3 dots and update your name. My name is Yamara Chaparro. I am project coordinator together with my colleagues who are joining us today. We have the same background, so we will be assisting you from the chat in whatever you may need, any kind of assistance. So here we start with the simultaneous interpretation services. We have been using it since the previous educational series, and if you would like to use the simultaneous interpretation services, you should click more, and then you may go to interpretation, and there you can select the language that you prefer. For Spanish, you don't need to do anything since the main room is in Spanish, but if you prefer English, you just need to click English as your preference. For today, we have the general guidelines. We are going to be talking about the TTELP project, the ECO methodology, the credits for continuous education, the evaluation metrics, the pre-test educational talk, post-test Q&A, clinical cases, and some brief announcements. And now we would like to remind you that if you already registered for this educational series on the chat, you're going to see a link where you could fill out the enrollment form, the registration form, and when you fill it up, and you will be able to have the credits for continuous education for those who qualify. On the chat, you're going to find a link to register in English as well as Spanish. For the general guides for this educational series in ECO, please turn on your camera so we may see you. You can also enable your microphone so you can engage in the discussion, or if you have any question, remember that you should always react if there is any question and enable your microphone so you get involved with the conversation and you can share your experience, which is so important for this ECO series. And also please type on the chat any moment during the presentation. This educational talk is thanks to the TTELP program, Telemedicine Technology Enabled Learning Program, that is funded by Health Resources and Services Administration, HRSA. And the objective is to connect specialists from different academic centers with primary healthcare providers in rural areas, compliance with the goal of facilitating and improving best practices and to increase the access to patients for primary care health with quality services. Our initiatives, as we had mentioned, we have the ECO project, the digital library, remote learning, and a directory of telehealth providers. And now, what is ECO methodology? It has 4 pillars, and it is to apply technology to make the most of the experience to share best practices to reduce disparities. We study cases to facilitate learning and manage the complexity, and also to have a database to monitor the records. So as a summary, here we have specialist physicians who are going to be sharing their knowledge with you, or primary care uh, providers, and you're going to be taking all that knowledge for the benefit of your patients. And for continuous education credits, once you complete the form and you have the link on the chat, you will be receiving those who are physicians, nurses, and nutritionists and dietitians. You're going to be receiving information. Uh, this is from the Medical Sciences campus. So you need to complete the enrollment and take the post-test and pre-test. And we need you to uh, engage actively in the conversation. And now we're going to continue with Alexandra. She's going to talk to us about the evaluation metrics. Thank you, Xiomara. In this series, the same as the others, we have the surveys and the pre-test and post-test. And through this test, we are going to be evaluating the implementation of the applicable practices. And in these areas, the different experts are going to be providing a tool based in evidence. So you're going to see additional questions in the pre-test and post-test, only two additional questions. So we appreciate if you could answer these questions, providing as much information as you can. This is going to help us to benefit you, because we want to share that knowledge based in evidence from our experts, and this is part of the evaluation of this program. In addition to that, we have some clinics that are going to be participating in the evaluation, but in a more integrated way. So if you work at any clinic and you're interested in participating in this study, this evaluation related to the ECO series, we invite you to share your information with us. You can write to our email, or we also have our telephone number. The contact information is on the screen. We have an incentive for participation to the clinic. For participating in the clinic assigns any healthcare professional who will be the designated person to engage in our series. So the clinic and the health professional receive that incentive. So I leave you with this information. If you're interested, please let us know through email or a phone call. Thank you. Thank you so much, Alexandra. And um, you can take a screenshot with the contact information on the screen if you're interested in collaborating. So you may contact us. So now we will continue with the pre-test. It is already open, so you may start answering the questions. Those participants that are not able to see it on the screen, you may reach it with the link on the chat or scanning this QR code that you're seeing on the screen. The pre-test is going to be open for a few minutes so everyone can fill it out, but it will not be open during the session, only for a few minutes now. Now I am going to continue with our doctor's presentation. Welcome again. And Dr. María Rodríguez Santiago, thank you for joining us. She's going to be talking about atrial fibrillation and prevention of thromboembolic events. So I'm going to stop sharing my screen so she can continue. Welcome. Good afternoon, everyone. Can you hear me all right? Yes, we can hear you very well. Thank you. So then I am going to, good afternoon again. Many of you already know me. I am happy to be here again. My name is Dr. María Rodríguez Santiago. I am a certified cardiologist. I am here in Guaynabo at your service at the San Patricio Heart Institute. Today we're going to be talking about atrial fibrillation and the prevention of thromboembolic events. So let's continue. So these are the objectives for today. We're going to start with the definition, the prevalence as usual. It is so important to talk about this and what can we do to decrease the prevalence and the progression of AFib. How can we diagnose it, treatment, and what to do when a patient with AFib needs to have some kind of procedure, how we can transition to that anticoagulation. Starting with the definition, atrial fibrillation is the most common sustained arrhythmia, more prevalent, and it is characterized by depolarization or electrical activity in the atrium, particularly in the left atrium, and these are depolarization and erratic activations. They don't have any order. We always need an event to start it, premature, an anterior premature, and a substrate to sustain it. And this definition is going to be important because we're going to see that many medical conditions and many risk factors make this atrium to deteriorate, to get fibrosis, and to create that perfect substrate so that many electric circuits can keep active. So the theory and the mechanism of this arrhythmia is through many re-entry circuits. And as you can see, let me share a link. As you can see in the electrocardiogram that we're going to see a better picture later, sinus rhythm, it means that there has a atrial depolarization that comes from the sinus node. And by definition, if we say that the rhythm is sinusoidal in the electrocardiogram, it's just that we see this ball that we were here, a P that is positive, and specifically in the limbs 2, 3, and F that are the inferior limbs. When we don't see it like that, and these P's are not present, and there is an irregularity between this QRS complex, particularly R, and the other R, this difference, it's very different, of course, this distance from the other. And so we are seeing an irregularity in the electrocardiogram. The prevalence, as I said before, it is high. At least from 3 to 6 million people in the United States have AFib, and it is expected that in 2030, it is going to double that prevalence. Around 12 million people will be having it. So we believe that 1 out of 3 people have a lifetime risk of developing AFib when they are 45 or 55 years old. On the charts that we see on the right, these are from the 2024 guidelines for AFib from ACC AHA, and the summary is that overall the prevalence is increasing because of the age, it increases by sex, both. It is increasing as well as by race. And the problem is that AFib is not only an arrhythmia, it is not a benign arrhythmia. The process of diagnosis and treatment and AFib doesn't end when we are diagnosing. On the contrary, there we start a process not only of diagnosis and treatment, but also to continue evaluating for the risk that from there on we can perceive in the patient. The risks may go from they have double the risk of mortality, a twofold risk of having a stroke, or more risk of dementia or cognitive disease, myocardial infarction, 5 more risk of having heart failure, almost double the risk of chronic kidney disease, and more risk for peripheral artery disease. The patients may present these symptoms They are very vague. For example, palpitations, shortness of breath, fatigue, chest pain, dizziness. They may say that they don't feel like they can do the daily activities as they did before. And yes, we need to see it now as a sum that these patients are at a higher risk of these events. And I am going to talk about the risk factors and why this is so important, because many patients, they're going to ask the same question. Why does it happen? Where is it coming from, this AFib? And AFib is what nowadays we emphasize in the guidelines. It is the sum of many risk factors that combine together and that have made the left atrium of the heart not only to enlarge in terms of size and volume, but also to turn more with fibrosis. The main risk factor is age as we get older, as you can see on this chart. Then there is an increase in the probability of developing AFib. And as you can see, at least it is believed that the prevalence is 1 out of 10 people at 85-year-olds are going to develop AFib. Another risk factor in terms of lifestyle is maybe smoking, directly related, and we have seen in several studies obesity. And we have noticed that on the other hand, when patients lose weight, we can decrease the burden of AFib, the burden of disease, the symptoms, the recurrence, and the progression. Also, we have seen that patients who have class 3 obesity in their BMI, having a bariatric surgery may help to revert AFib. Exercise, having a sedentary lifestyle, it is associated with AFib, with an increase in incidence of AFib. And interestingly, we have also seen that patients with extreme physical activity, especially elite athletes, also they have a higher risk of developing the condition. And also alcohol, it's very interesting because there is a relationship directly proportional in terms of doses. The higher the alcohol intake, as you may see here, the higher the likelihood of developing the condition or higher risk. And it is also a dose response. One drink, this is a risk. As you increase the drinks, you are increasing, almost doubling the risk. The most acute period of when to develop this arrhythmia is 4 hours after taking alcohol. And also we have seen that when they're having a binge, drinking too much in a short period of time, they have a higher risk. So in this chart, we can see that there are studies that are so important and very well done, where they separated some cohorts, a group of patients that followed an adequate nutrition, diet, and exercise in patients who had a BMI greater than 27, and they were not following these recommendations. And we noticed that the patients following the recommendations in terms of diet, exercise, and behavioral counseling, they were able to decrease the episodes of AFib. Other risk factors in terms of medical conditions could be patients with hypertension, diabetes or pre-diabetes, chronic kidney disease. And we have seen that AFib is a cause for CKD, but CKD not cause for AFib. Also, uh, sleep apnea patients, and we have seen studies that have shown that treating sleep apnea with CPAP decreases the prevalence and the incidence of AFib. We're going to talk more about that later. It has not been proven in randomized studies. And also, patients with thyroid disease or hyperthyroidism also have a higher risk. The patients with hypertension at a higher risk of developing AFib are those who already have evidence of hypertrophy in the left atrium. And this is important, this finding, because we are going to see it when reading the hypocardiograms. Other risk factors in terms of cardiovascular diseases are the list that we see here: coronary artery disease, congestive heart failure, uh, HR, HFrEF or HFF, which is heart failure with preserved percentage of pumping, valvular heart disease, uh, cardiac surgery, especially those patients after a CABG or a bypass, and pericarditis. So here it is really important. What do you think? I know that we're going very, very quickly, but what do you think? Is this AFib or do you think that this is an artifact? Because we're limited on time. The answer is that this electrocardiogram is an example of an artifact. And this is the first distinction that I would tell you that in fact, in the words of cardiology, they make us do that distinction. And I could say that the first that in general caught my attention, it's seeing the intervals from R to R. Sometimes there are electrocardiograms with AFib that the distance between one and the other, this peak here and this peak here, it's very short. But generally, they are going to be very erratic, irregular distances. And that's why AFib in the electrocardiograms, it's a classical irregular because between R and R, the distances are very irregular and erratic, very different. And that's the first clue here that it doesn't look like AFib. And the second clue is that if we notice here, as, as when you see a baseline or a line that is looks crazy, but in the other one doesn't look that way, we may think that it may be an artifact. So the first thing that I would tell you is first, let's find the complex QRS and check the distances if they are the same or different. And second, take a look at two different leads to make sure that the baseline looks the same, erratic on both sides. Then that may be a clue that this is an artifact because the noise, it's not uniform. So the first would be, and the most critical would be to corroborate and confirm that the patient in fact has AFib and that it correlates with the clinics because if we see a patient with essential tremors or if they have Parkinson's disease, it is very probable that it correlates with what we are seeing on the electrocardiogram. So this is, in fact, an electrocardiogram of a patient with AFib, as I explained before. The R's, the distances between the R's, I apologize, Maria, but we are not seeing your presentation on the screen. Oh, I apologize. Can you see it now? Yes, we can. I apologize. As I was saying, the first thing that we are going to check is that the QR are those are complex. The distances between them are irregular and different. And if we take one chunk of the AKJ, ECG, and a space and another space, we see that there is no irregularity, and that's why it makes it very irregular. There is no P's that we can identify, no discernible P waves, and there's an absence of an isoelectric baseline. Nowadays, we have new strategies, and the patients, many times, they already have their presumptive diagnosis and they have their concerns, and they tell me, but my watch is telling me that I have a fibrillation. That is very common now. And our job is, first of all, to corroborate that what it is showing in our wearable devices, it is right, it is accurate. So now we have devices, we may find them even on Amazon. You can get them, and this device is showing us 1 to 3 leads. They have their fingers and it shows them their electrocardiogram, the same as the watch. To recommend this, this is a class 2A recommendation. I recommend it to patients who already have AFib, and I tell them, if you feel the palpitations and you have a watch, if you have if you can afford it and you have that privilege, you can do it. Having that information, I think it is always helpful. Of course, some patients may get very anxious. It will be better to check them at the office, but some of them feel calm and they bring the paperwork and you verify it and you can reassure them. Also, with younger patients who have it, it's a good way that when they feel palpitations, I tell them, when you feel that way, put the finger and check, and then we can rule out arrhythmias. But now, the most important strategies that are more proven are the 24 or 48-hour Holter. This one here, and I tell them you are living with a Game Boy and a case, and it is going to track your electrocardiogram for 24 hours. They can do all the activities that they do. They can run, they can work, a normal day. And we have these kind of devices that it is a patch that lasts for 14 days. And we also have devices that are implantable and they go below the skin subcutaneously. We can do it at the office with local anesthesia. The difference is basically that they are used depending on the frequency of the symptoms. If the frequency of the symptoms is on frequent or occasional, then we choose a device like the 14 days or the loop recorder because it lasts longer on the body. Again, this is really important, and the diagnosis we can do it once we have corroborated visually ourselves, that we have corroborated the electrocardiogram and we have seen the fibrillation. If they bring you a track that suggests, but you are not so certain, you cannot see it. It could be an artifact, you cannot see it clearly. It is complicated to make a diagnosis, and 100% not to do it if they just tell you that the watch gave them an alert for an AFib, because it may be many other things. And these are the new guidelines. They change a little bit because now they're treating the condition as a progression, and they even start before it develops, and having a risk of fibrillation is stage 1, and these are the risk factors that we discussed initially, and that's why we mentioned them, because now the guidelines are emphasizing that AFib starts before it's showing up. Second, stage 2, pre-AFib, and stage 3, it's when it is diagnosed with the different definitions based on time, and I'm going to explain more now. So these are the AFib definitions. Paroxysmal, it's that it lasts and it terminates in less than 7 days. Persistent, it lasts more than 7 days and it requires treatment or intervention. Long-standing or persistent AF is more than a year continuously, more than 12 months, and permanent AF, it's that we made a decision between the patient and the physician not to try any other rhythm control. And valvular AFib, even though it is a term that is not used anymore, but I want to distinguish it because we are not touching it. This is a secondary fibrillation to a mitral stenosis. It may be moderate and severe, or because of a mechanical prosthetic valve replacement. So this kind of AFib, this valvular AFib, that we call it for many years, it is treated differently and it is treated with warfarin. But I just wanted to make that distinction. So this is as part of the history of what we should look for. The same thing that we mentioned before, these are risk factors that they explain why AFib was developed, and we need to have an electrocardiogram, lab work, echocardiogram, and an X-ray, chest X-ray to help identify if there is any lung problem. The treatment, we are based on these 3 pillars. First, we need to evaluate the stroke risk, because based on that, we are going to recommend anticoagulation. Second, we need to talk about modifiable risk factors so we can prevent the progression, to reduce the burden of the disease, and to avoid symptoms, and how we can manage the symptoms and what strategies, if we are going to use rate control or rhythm control, the number of pulsations per minute. The first phase of the treatment is modifying risk factors. And this is something that it is an important change in the last AFib guidelines for 2024 because they realized that each one of these factors had randomized studies and they had data that showed that treating each condition, we were able to reduce symptoms, progression, and the burden of AFib. So now it is not a matter of only, well, if you do it, it's cool. No, no. Again, since they ask you, and why is it happening? Why is this showing? Well, because of all these factors, and if you can control these factors, you can improve the condition. So weight loss, it is recommended that if the patient has a BMI over 27, to reduce 10% of their weight loss.
Physical inactivity, we have to tell them to exercise moderate to vigorous exercise training for 210 minutes a week. And we have to recommend also for them to cease smoking, minimize alcohol, less than 3 drinks a week, and abstain from alcohol and avoid binge drinking or drink a lot of alcohol in a short period of time and control diabetes and HTN with standard of care. And we have shown there are studies that have shown that AC, ACE and ARBs and MRA have been associated with lower AF incidence in RCTs. So we know that we're talking about losartan, valsartan, espironolactone. It has diminished the incidence of AF. I show you this because there has been always a perception that sleep apnea was part of treatment for people that have AF. And of course, yes, some 50% of patients with AF also have sleep apnea. There are very important studies, randomized studies that have not shown yet a diminishment because of the use of the machine and the symptoms or the progression of fibrillation. We have seen improvement in smaller studies that are observational. I always tell patients, let's do the screening, but it's just an indication because we haven't seen an improvement that is significant. And of course, what about coffee? Coffee, it's a myth. They don't have to stop drinking coffee, especially if these patients have been drinking coffee before. Obviously, if they relate the symptoms and palpitations with the cup of coffees, then we tell those patients, you know what, maybe this is not an option for you because it causes symptoms for you. But in general, and to do away with the myths. We've had a lot of studies, and this is from 2025, and they realized actually that the patients that took their cup of coffee, drank their cup of coffee, in comparison with those that didn't drink a cup of coffee, they had a diminishment of relative risk. So if you like your coffee, drink your coffee. Who needs anticoagulants? The first thing that we're going to do is identify and diagnose fibrillation, AF. And the first thing is to calculate the chat DAS backs. So this is what I call it, chat DAS BA. There was an earlier version of it, and this is uh, a better tool. That is the function of the score from this tool, because as we add the risk factors as we see them in table 10, each one, and sometimes they have 2 points where you find it under their letter, we start adding and we find what's the annual probability of them having one stroke. So that's why we're going to use that strategy. There's some important data that it's important to emphasize. In hypertension, in the guides, it shows or they diagnose as having more than 140 in systolic and 90 in diastolic. In the general practice where they have hypertension stage 1 and they have to take medication, that patient is getting that point. And of course, this is something very nuanced and maybe controversial, but there are patients that when we're not, uh, when we're indecisive, and I'm going to explain why. If we are not convinced totally of prescribing anticoagulants, and we have looked alongside with colleagues to do carotid studies, uh, check the legs with arterial sonograms if there are visible vascular disease, plaques, because for me, that would be one point in the vascular area. But I mention this because right here, to have a diagnosis is to have an infarction, to have uh, intermittent claudication, surgery, etc. So this patient gets to your office, you use your calculator from Metcall, or you do it with your brain, and you start checking each one of these factors. If they have heart failure, hypertension, their age, diabetes, some evidence of thromboembolism previously, a vascular disease, age once more, and the sex of the patient. There are several additional factors that are not considered in the CHA-DAS score. But if we see them, we know that this patient is at a higher risk of stroke events, for example, and are these that I show to the right in table 11. And I give you that because, again, for standard of care and the guide, we're going to use the Chad does Bass, but we have to keep in mind that it's not black and white, that these are other factors that we could be in a mistake in terms of choosing to anticoagulate. This is the form for Chad does Bass, how you see it in the calculator. And this is the information that it gives us. What this tells us and the interpretation is that if a patient has more, the same or more than 2 in chest bath, they already have 2.2% of stroke probability. And as we add points, the risk for this stroke increases. So if a patient has, maybe this sounds as a low, like 2% annual, we're using anticoagulation. This is not that much, but we have to think about population, 2 of 100 patients that goes to your clinic, and then we have 20 out of 1,000 and 200, and it goes on and on. So it becomes a population problem. This is very, very important. And I would say that this is the most important slide. Patients that have an annual risk of thromboembolic risk, the same or more than 2% annually. And we use the tool for Chasdas Basque that has a 2 or more in men or 3 or more in women. These patients need anticoagulants immediately. Before warfarin, we want the dose, except when we have valvular fibrillation. This is a different topic. This is what's new in this clinic, and this is class 2A, so this is reasonable. And this is reasonable to start patients in anticoagulants even when the stroke risk is less than 2%, 1 to 2%. So 1 in men and 2 in women, anticoagulation is reasonable. And that's why I emphasize on the table number 11 in the past slide, because it mentions other factors that are not part of CHASPAS and could still increase risk of strokes because of this indication, because even if the CHASPAS uh, talks about a woman that has obesity, hypertension, and all of these conditions, I would strongly advise somebody like that to start with anticoagulants. Step 3, once we have worked with evaluating that. We have to evaluate bleeding risk. And I give you here a list that is part of a paper on what is considered as major criteria or minor criteria. And we're going to try to optimize the bleeding risk. We are not using this data to say, no, we're not going to do it. It's not, there's no anticoagulation. No, we want to evaluate what we can improve. And if after improving it, the bleeding risk is too high, we evaluate case to case. But if we can improve and the risk of bleeding has lowered and there is more benefits than risk, we will start with anticoagulants. And what are we going to use the DOACs in the majority of the scenarios? We have apixaban, rivaroxaban. We would rather have apixaban when we have um, kidney dysfunction scenarios because we have an additional way of modifying depending on the kidney function. And two, we'd rather have it in elderly patients because there are studies that show that there is less risk of bleeding, especially in the gastrointestinal area. So that is usually what we prefer. The only problem is that it has to be taken twice a day. We worry about compliance. Look at this. The standard dosage is 5 milligrams, but if they have two of three criteria, we have to go down to 2.5 milligrams twice daily. And the criteria is that they are 80 years old or more, 60 kilograms, or serum creatinine higher than 1.5. And of course, there's not that much data on patients with dialysis, but there are meta-analysis that says that we can start apixaban with these patients, and that is what is recommended in patients that are with kidney dysfunction or dialysis. And I'm going to leave the rest of the modifications for kidney disease. I remember how I modify it in rivaroxaban. I see the 550 or more, 5, 50 or more, the dosage is the same. And if it's different, uh, it's 15 milligrams once a day. If they have a very severe liver disease, these patients should be in warfarin, and that has to be discussed with the gastroenterologist. These are the DOAC's pearls that I just mentioned. In terms of aspirin, this is a very important slide too. This is not the same. It's not an alternative to anticoagulation. Patients are going to ask you. I have a patient that would just get to the clinic every time they were still using aspirin, and we had to document everything that we told them, but we would show them the risk of bleeding is exactly the same with aspirin. You could bleed with this, and the other. The thing is that with the aspirin, it's not really doing anything with the problem, so it's bad with bad. And lastly, what strategy are we going to use, rate versus rhythm? Basically, patients that have been with the condition for longer, they are more elderly. We see changes in echocardiograms with very large or severe regurgitations. These are patients that we don't want, although we're trying to control rhythm, it's not going to improve and they're going to go back to fibrillation. So we'd rather control heart rate versus patients that have just recently been diagnosed. They have a lot of symptoms or they have dysfunction of the ventricle. We want to be very aggressive and we want to take them swiftly to management of rhythm. I leave here for you the treatment with beta blockers. This is for a management for rate or pulse per minute. Usually these are first line medications. We have to be very careful in not utilizing diltiazem or verapamil because these are calcium channels, and this will not be good for certain patients. And the target is to have, according to different studies, that we want less than 100 pulses per minute as they rest. So there are non-invasive strategies for rhythm control. Usually, if I see a patient that has atrial fibrillation, I check the electrocardiogram. This is a patient that is paroxysmal or persistent, but we caught it in time relatively. We're going to refer them for cardioversion. Usually we do the cardioversion, and before that we have a transesophageal uh, sonograms to make sure that there is not a thrombo in the appendage of the left atrium. If the patient has been diagnosed for less than 48 hours, we could proceed to have a cardioversion without the transophageal sonogram. But really, if we can do it, we should do it. And if it's been more than 48 hours, we do have to perform the TEE before the cardioversion. After the cardioversion, rhythm control, even chemical with medication, just or electric, we have to give it 4 weeks of anticoagulation after the procedure. 4 weeks. I am showing invasive strategies for rhythm control when we're talking about referrals for ablation. Electrophysiology goes in with a catheter. It can be cold or thermal or radiofrequency. They go into the pulmonary veins and he burns them because that's where the most frequently found arrhythmia is found. And the guides have changed and they say, well, refer for rhythm control earlier than doing it later. It's very important. Patients are always asking if these interventions alter or change the fact that they don't have to take the anticoagulant medication. That is false. Anticoagulant is determined, or the need for it is depending on the risk for stroke. And we already mentioned that this is for the CHAS-4. And that only tells us these strategies only tell us the need for medications for control of rhythm, rate control, pulse control. This is for the management of symptoms and the management for these symptoms. We are getting to the last part of the presentation. Invasive strategies for rhythm control when they're very advanced in the process and when patients have a lot of symptoms and the fibrillations are coming in and out of the hospital because of this. And these patients, we recommend a blade and pace strategy. We're looking for the atrium ventricular ablation. We cut or shock the circuit, the electrical circuit, the atriums and the ventricles don't communicate. And we recommend this generally for sedentary or older patients along with a pacemaker. And periprocedural management, patients with AF that are using DOACs, they don't need bridging. That's it. That's it. The interruption of treatment is going to depend on three things: the agent that they're using, and that's all in the table provided in the slide, the agent or medication, the renal function, and the procedural bleeding risk. If it's an endoscopic dental extraction, ophthalmologic procedure, or a percutaneous vascular accent catheterization, that's a low bleeding risk. If it's not that, it's a higher risk. Depending on those three things, the majority of times we're going to stop 24 to 72 hours. And in the majority of the cases, we're going to start the next day. With warfarin, it's different, but with DOACs, that's the rule. I'm going to leave you here the summary with the common misconceptions. And we have spoken about this yet. The take-home messages, the most important: diagnose AF correctly, make sure that it's not an artifact, look visually to see if the concern from the patient is in fact true. Prevention for strokes is the most important thing. We have to calculate this risk with the CHAS-VAS tool. We'd rather use Daux over warfarin, and the bleeding risk should be optimized and not used to withhold anticoagulants. And of course, we want to refer for rhythm control early. That is for the benefit of selected patients. I am leaving you here the practical algorithm from 1 to 4, and you can go checking in each one of the areas of what you have to do, how to diagnose, and how to manage. And these are the references. I'm sorry. Thank you so much, doctor. We're going to continue. I hope that doubts, questions are already, you are all ready to share in the chat. And we're going to go also for the post test. Thank you. Please don't leave us yet. Here we go. We already have the post test open. For all of you, you can scan the QR code. And we already also have the link in the chat if you need it. While you are answering your post test, this is the moment to ask your questions, something that maybe you're curious about or created a doubt. This is the moment. Please open your microphone. You can react also, or you can write in the chat and share your question. I understand that the doctor is going to be providing the applicable practice tool, I believe. Am I right? Yes, I will send it to you. Okay, yes. We have somebody asking a question. Is coffee protective, reducing AFib risk? I think that it's obviously what the studies are saying, which is really interesting. And I'm going to try to provide it all for you. I have it here. Well, these studies are saying that in patients that are already drinking coffee, they were coffee drinkers already. Yes, it did have a reduction, a relative reduction of risk. So yes, we could say that it's protective, but we have to establish first that these were coffee drinkers already. That's what the studies say. Thank you so much. We have Cari Olga Estrellas is asking about cannabis. I am so sorry. I don't understand the question. Kathy, can you write the question or open your microphone? I'm trying to find her in the chat. She just wrote the word cannabis, and we're trying to find Kathy to see if she can elaborate on the question. I don't know what the question is for sure, but we have not seen any study that I know of or about risk decrease through cannabis, but I haven't seen any studies that either that have diagnosed that the risk is higher or detected causality that one thing leads to the other. But there's a lot of data that has shown that cannabis, when patients use it a lot and they start to create resistance, is associated with palpitation symptoms, but not that I have seen myself. We have Gadi in, yes. Can you hear me? Yes, Gadi, we can hear you. In my practice, I've had study patients that are using medicinal cannabis supposedly because of anxiety and other issues. And afterwards, they are presenting episodes of palpitations, even dizziness, and we've have had to refer them to cardiologists because they come out with tachycardia, symptomatic tachycardia, and they've had to start using the 30-day halters. Most of them use vaping, use cannabis through vaping, but we have seen that, and I don't know if there is some study, maybe locally in Puerto Rico, that has identified this type of association directly, causality between the use of cannabis and afterwards having atrial fibrillation conditions. Yes, and you are right. I think that is something that I have seen also. But what we do know in studies that are smaller and observational, they had seen that patients that are using too much of the cannabis, they do bring forth palpitation symptoms and they could develop arrhythmia, but it hasn't been studied in randomized studies to see if there's a direct correlation between cannabis and atrial fibrillation, as we've seen with sedentarism, smoking. But I am in agreement with you. A lot of patients, especially when they have been using cannabis for a long time, they develop, I don't know if to call it dependency or resistance, but I see them being more symptomatic with the palpitations through prolonged use. You're right. But again, these are small studies, observational studies. They've seen some association or relation. Large studies, they're still in the works. Thank you so much, Doctor. We also have two other questions. We have Cindy. If you can open your microphone, we invite you to present your question. The same for Nancy. I'm going to give you a few seconds and you can be part of the conversation, please. Can you hear me? Hello. Yes, we can hear you. My name is Desiree Pagan. I don't know why it shows another name, but anyway, I know or I understood that aspirin is not or can or shouldn't be used. But why is it recommended for some patients to prevent, I'm guessing, heart attacks? Exactly. That's a great question. If it's purely for atrial fibrillation, no. Literally, basically, we're harming because there's a bleeding risk and no benefits. If once more, if it's to say, listen, this medication is to reduce stroke events, aspirin is not going to do anything at all. But in some patients, particularly those in a short period of time near to a heart attack, if they have atrial fibrillation and they had a heart attack, we leave them for 7 to 1 month in a triple therapy with aspirin, Plavix, and Eliquis. This is for patients that have just gone through a heart attack. They have atrial fibrillation, and we use that therapy. That's the only moment when I could tell you that we can see this. Aside from that, once more, the recommendation is for atrial fibrillation to say aspirin. No, no. In fact, if it's for that, I tell them, and I tell them like this, if it's for that, don't take it. I'd rather you not take aspirin at all. If you are worried or concerned about bleeding risk, don't even take aspirin because we're not really doing anything. Thank you. And now we're going to go to Nancy. Go ahead, Nancy.
Hello, my question is if there is any restriction in physical activity or specific recommendation in terms of intensity. Nice. Well, the guidelines tell us moderate intensity to rigorous. Moderate is literally that they are walking and they can keep a conversation, relax, but they cannot sing. That's moderate. And vigorous is that they are agitated, that they are running and they get agitated. That's we could go all that range. And what it is recommended is 210 minutes every week. So guidelines to reduce cardiovascular risk goes from 150. And these are a little more specific with 210. But in theory, what I tell them is if you can start with 30 minutes, 5 days a week, that would be great. There is no kind of restriction, again, in terms of that you cannot do anything because your pulse will go high. No, no, that's a mistake. In fact, since the pacemaker of the heart, which is atrial synod, it goes up when you're exercising. In theory or physiologically talking, that kind of arrhythmia is suppressed during exercise. So yes, at least from 30 to 40 minutes, from 5 times a week, and with moderate to vigorous intensity. It is very big. So it is the same as a person who doesn't have the condition. Exactly. Exactly. Physiological, we are expected to be the same as a person not having the condition because no, it start acting normally. Also, Norma has a question. Norma Rosa Serrano. Please go ahead, Norma. And we cannot hear you. You are muted. Okay, now. In terms of what is echocardiography, the only diagnostic study for, is that the only study for problems in the atrium? No, we could also use, even though I would not refer them for that, but they could also be seen in a CT with a heart CT and also a heart MRI. They could be the atrium, the size. Yes, but the most invasive, the faster the echocardiograms. Thank you, doctor. Of course. Thank you so much to all the participants for your questions. And Dr. Rodriguez, thank you for answering these questions. We're going to continue. And now we are going to see the clinical case study for today. Remember that you can submit your clinical case, and we're going to continue with Ms. Nicole Marrero. She's going to explain how to submit a clinical case, and then she will be presenting today's case. Thank you. Please go ahead, Nicole. Good afternoon, everyone. My name is Nicole Marrero. I will be moderating the clinical case. And if you have any clinical case that you would like to discuss for this series, you can submit it sending an email to assistencia at persciencetrust.org or to my personal email address, which is nmarrero at persciencetrust.org. So we could continue with the next slide for today. here we have the discussion for this session. And briefly, we have sometimes they submit a brief description of the patient, lab work, studies, and here it's my email address, nmarrero@prsciencetrust.org or asistencia@prphd.org. That's a contact information for any case you would like to submit. And here we have a history and physical examination. This is a 64-year-old woman. She has been pregnant 3 times, no complications, and she has a history of hypertension and dyslipidemia. And that's why she was looking for cardiovascular care. She underwent menopause at 51 years of age, and 6 months prior to coming to the office, she had a near syncopal episode while cleaning her backyard on a hot summer day. She denied having palpitations, chest pain, shortness of breath, loss of consciousness, dyspnea on exertion. She has no prior history of hospitalization. She's age appropriate for cancer screening, and preventive health maintenance are up to date. Also, she doesn't have any history or surgical history. Her father had type 2 diabetes. The mother had asthma. She never smoked. No alcohol use. She is a retired teacher and she walks almost every day for 30 minutes. And she's taking losartan 100 milligrams a day and rosuvastatin 5 milligrams a day. In the physical exam, vital signs, she had 128/76 for blood pressure, a heart rate of 76, and a BMI of 25. And she doesn't have anything else remarkable in terms of the physical examination, no other indicators. In terms of the laboratory results, we have them on the screen. And in the next slide, we can see also the ECG. And on the next slide, we have the 24-hour Holter. The next one, we have the 2D echocardiogram. So, as an initial question, how would you work in this case for this patient according to your specialty as a healthcare professional? You can raise your hand. If you would like to, you can. I can see Juan Roman. Welcome, Juan. Yes, you can enable your microphone. Hello, good afternoon. And hello to Dr. Rodriguez. Good afternoon, everyone. How can we work this case? Well, I would start definitely ruling out if this syncopal event, it is a 64-year-old female. She's relatively young, and within her history, she's showing hypertension. It is under control with losartan. So the first, in the physical exam, I would rule out whether there is a possibility of a syncope with a neurogenic or cardiogenic origin. But I would focus on, and because we have already seen the electrocardiogram and we see that there is a sinus normal rhythm. We had a P wave to distinguish if it is an AFib. I would check that rhythm that they are missing. A P wave, the atrium is not contracting as the doctor explained. So what would I do at the emergency room? I definitely would order an electrocardiogram, an chest x-ray to rule out a neurological event. And it is possible that I may order a head CT scan. And after the physical exam, obviously, we will need to check the mobility of their lower and higher extremities. We need to hear the heart to find any murmur in any valve. So we also need to check the rhythm if they have tachycardia over 100 beats per minute, and to find out if there is an arrhythmia, maybe an embolum has been detached, if it is obstructing the carotids, and we may have an ischemic event or a syncope. So I would go down that route with a primary evaluation, with electrocardiogram, chest x-ray, definitely a good physical exam, a head CT scan. And I think that would be the first that I would do. And also, I would like to consult with Dr. Rodriguez, definitely. So she can visit the patient and evaluate the patient as well. Thank you. Thank you, doctor. And here we have uh, Kathy Estrella. Please go ahead, Kathy. Yes, good afternoon. Seeing the lab work and the halter that she had, if you can show the halter uh, chart, we can see that in those 24 hours, there were two episodes where there were significant. The R's are irregular, the spaces between them, and obviously, we would refer the patient to a cardiologist to see if they can have an extended halter. It may be a 7-day or a 30-day halter to check and to quantify how many episodes she's having with that irregularity or arrhythmia, to then be able to determine more accurately the protocol to be implemented for her. The patient, according to what was mentioned, she was working on her yard, cutting the grass in a hot summer day. So it may have been excessive sweating or dehydration with an unbalance in the electrolytes that could have made a trigger. So, so she had that pre-syncope. But I would go more in the cardiac way because of these two episodes present in the Holter. Thank you very much, Kathy. Any other comments? Any other question? And we may go back to the lab work if you would like to see it. Diana, if you have any recommendations for this case? Yes, excuse me. And regarding Dr. Estrella's comment that it could have been an event because of the hot summer day, it may have been a heat stroke. Definitely. And we need to check the electrolytes, sodium, for example. I didn't notice in the numbers or if the doctor could have seen them. Yes, they were doing well. Sodium, potassium, a little bit of high glucose, 103, if I am not mistaken, 102. But the others were fine. Thank you. 140. Here, Diana Torres Arce is typing. I also considered the factor of dehydration, even though VUN and the electrolytes are fine, as Dr. Juan Roman mentioned. Esther Irizarry, she's typing here on the chat. I was able to see that the glucose was high, and this is related maybe to having diabetes. It's a question she has. She has a family history of diabetes, type 2 diabetes. That's her question. Well, it's pre-diabetic. Obviously, we would need to call the endocrinologist, but yes, it is above what is expected, 100 or less. And she's 102. I don't have the A1C to add more information, but it is not in the pre-diabetes range. It is not in diabetes. It is pre-diabetes. And regarding a comment from Dr. Roman, I agree that definitely the approach to this case in a hospital scenario, or if this same patient would come to the hospital, then the concern certainly would be what you just mentioned, evaluating the near syncope, the dizziness, or about to lose consciousness. It could have been something worse, like a TIA or a heat stroke, or something more concerning. However, in the office scenario, if we can see the case again, because for me, it's an interesting case, and I wanted to show you something that is particular, and it's that it's a 64-year-old female. She has a history of hypertension and dyslipidemia, and basically her she doesn't have a history of hospitalization, surgery, no toxic habits. She walks for 30 minutes. Everything is very unremarkable. But she told me that 6 months ago, when she came to me, she had experienced this dizziness, as if she were about to get dizzy. She was working on her backyard, but it didn't happen again. And in addition to this, she didn't have any other symptoms. She just came to establish care. But because of that history that she's telling me, as very well the doctor said, to rule out maybe a vasovagal or neurogenic event versus a cardiac event, syncope with a cardiac origin, I ordered an echocardiogram and a 24-hour Holter. And anything else, she has her health screening test, mammography, everything looked well. So far, what I have is a 64-year-old female with hypertension and controlled dyslipidemia because LDL, it was in 70, the pressure at the office was 120 over 76. Everything was doing well in terms of lab work. So I ordered this test to evaluate that event that happened 6 months ago. And thank God she didn't have any repercussions in her physical exam as it was discussed. So all of that is really important. So let's go ahead. Next one, please. And here it is the same. Basically, her medications, first line medication, control blood pressure. The physical exam was unremarkable. Next. Here we also have a comment from ODS. I don't know if you can see it. Dehydration cannot be ruled out. However, a chest X-ray and a Holter, a CT, excellent. Yes, all of that, and carotid as well. It can be done. We may consider all those are good tests, diagnosis tests, and also it goes together correlated to that syncope or near syncope event. That workup. Yes, I agree. But again, we also have the reassurance that it was like it sounded like vasovagal. She was under the sun. She was cleaning in the backyard all day long. So the history also was reassurance. But yes, I agree. All these tests are possible, and in fact, if we want to make certain, it's even better. The office ECG is this one. Essentially, it's a completely normal ECG, normal sinus rhythm, normal EKG. Next. And we have the Holter results. And incidentally, we found these two episodes. Let's go back. We had AFib episodes. They are proximal. Let's go back. And these are in the red boxes, as you were going to explain exactly. No, the 24-hour Holter, please. And I apologize. This one. Yes. Here we can see again. This is how we see them with the Holter results. And I tell the patient, uh, do everything that you do normally in a day. And we see precisely this, where we have short episodes. There are other patients with the burden of disease, so the duration of that fibrillation is all the time. Others are brief events that come and go, and they're proximal. And as you explained, the spaces between R and R are very erratic, and that's times where the patient is in fibrillation. And I found this case very interesting because so far, when incidentally we diagnosed her, and again, it could have been that symptom of 6 months ago, it could be, but again, it could have been a vasovagal or an orthostatic, a near syncope. It is not going to change the management right now. Obviously, we need to roll out other things as well. But I diagnose her, and then next step, automatically it is to calculate the chatbot score for this patient. If we calculate the chatbot score in Metcal, and I know it, but it is 0 point in her age because she's 64. She's going to have 1 point because she's a female, and 1 point because of her hypertension history. So right now she has 2 points. 2 points. And the guidelines tells, well, an annual risk of 2.2% of annual stroke risk are males with more than 2 points and females with more than 3 points. So in theory, and following the guidelines, she doesn't need anticoagulation at 64 years old. And in fact, that's what we did. Obviously, I explained all of this to her, analyzing also the table number 11 that we saw with other risk factors that are not considered in the chat box, among them, if her echocardiogram, and that's why we do echocardiograms. If we see that in the next slide, we can see it. Her hypertension doesn't have an evidence of ADH or hypertrophy in the ventricle. Her left atrium has a normal size. She's not obese. She doesn't have uncontrolled hypertension. Her kidney function is stable. Exactly. So she had a chatbacks of 2 and echo chatbacks of 2, and the risk factor, no additional risk factors. So at the time we discussed and we talked about all of this, I told her your risk of having a stroke right now is lower than 2%. We could start anticoagulation, and as I show you in the slide, it would be an indication of class 2A, reasonable, but If you decide not to do it now, it is fine as well. What I told her is that as soon as you turn 65 years old, your risk is going to increase because if you calculate the chatbacks at 65 years old, she's going to have 3 points, and it increases her annual cardiovascular risk of having a stroke increases. So during those visits, when she was 64 years old, basically we evaluated symptoms. In addition to the symptoms, we always evaluated if there is any additional risk factor for a stroke, that she doesn't develop diabetes, any heart failure, anything that would change that setback score. So I followed up on her. When she turned 65, her risk increased to a second one indication, class one indication at 65, basically, yes. But yes, when she turned 65, we talked again and she started anticoagulation to prevent strokes. And that's something that I wanted to show you because it happens when we are diagnosing younger people, 40 years old, 50 years old, and they only have hypertension, they have a Shadra score of 1. And that's a discussion to have with them. With the echocardiogram, we may have more evidence if there are other findings that may talk about a higher risk of stroke. And also, well, we need to talk to them about what is that AMA risk. Thank you so much, Doctor. Anything else that you would like to add to your recommendations? No. Well, we would also need to talk about what strategy, rhythm, or rate control, but we would take longer. But that would be another recommendation. For example, in her, very briefly, she's not asymptomatic. We had two very brief AFib episodes, only for a few seconds. She doesn't have symptoms. And for her, the strategy could be from not necessarily starting a rate control therapy. If it is very infrequent, those episodes, and she's not symptomatic, we may refer her to an electrophysiologist. So early, maybe not necessary for ablation, is what I mean. But also it could be the same if it is discussed with the patient and the physician, and they decide to establish any kind of rate control with metoprolol, it may be feasible. And if the patient has hypertension at the same time they have AFib, it is a possibility to unify one therapy with correct with carvedilol. That would be one of the reasons that we may start a beta blocker as a first line for hypertension. If the patient has fibrillation, I don't want them to take so many medications, and we unify the therapy with a beta blocker. Thank you very much for all information and all the recommendations. Also, we want to thank our participants for their comments and the questions that they shared with us. So we are going to continue with the survey. It is open now. It is going to stay open until the end of this session. Also, we have the link for that survey. You may find it on the chat box. And we have some announcements. Our next session will be next Tuesday, August 18th from 3 to 4:30 in the afternoon with secondary prevention post cardiovascular events. Again, we're going to have Dr. María Rodríguez Santiago. She's here with us today. So if you have any case that you would like to submit regarding this topic, you're going to be receiving on your email the link for that form so you can submit the information for that case. Again, on the chat, we have shared the link for the registration for those who would like to take the credits for continuous education. I would like to let you know that this Thursday, we're going to start the conversation on digital health here in Puerto Rico. And this Thursday, August 13th, we will be in Mayagüez. It is sold out already. This initiative is completely free of charge, but all the spaces are sold out. We still have uh, spaces for August 18th, and this initiative, these listening sessions are going to be in person, and we still have available for August 18th in San Juan, August 20th in Ponce, and August 25th in Atillo. So you may scan the QR code, those who have not registered yet, and we're going to be forwarding you the link so you can register on the session that is closer to you for your benefit. Remember that we have the digital library. We have more than 700 resources available on 18 topics with 11 formats, and you may look for information on the cardiovascular series that we're having, all the documents, the tools, the posters. You may access it and you may click cardiovascular disease, and you're going to see all the sessions that we have created. Now on the chat, you may find the link for the digital library. You may find the recordings and the presentations. So thank you so much, and we will see you next Tuesday. It has been a pleasure having you again, and it was a pleasure listening to you. Have a wonderful evening and take care. Thank you.